All right, I'm going to try to speed this one up. I'm going to try to be more enthusiastic, and I can't really do much about my crazy hair today. It just wants to stick up. My wife's been telling me that while she's listening to me record this today, it's going to be way too boring. It's going to put everyone to sleep. So I apologize if I have put everyone to sleep. Hopefully my voice can be a little more enthusiastic, but I've been talking to a computer for like 6 hours today. So I'll work on being a little more enthusiastic. All right, so clap my hands. We're going to go for it. Common ortho X-rays. This is the fun part where we get to put everything together and kind of see what we're going to be doing with these X-rays, okay? How we're going to read them, learn some special tricks. This is what I really had fun preparing. So elbow X-rays are a really common X-ray that you're going to be doing. It's something that you don't want to mess up on because, especially in children is where you're going to be doing these elbow X-rays, you don't want to miss a supracondylar fracture. Supracondylar fractures are very commonly associated with neurovascular complications, and they can be very hard to see. They can be occult fractures. And if you miss them and they have some sort of complication, that liability is on you. So you want to be the best. Obviously, you're going to have a radiologist read all of these. But just so you know the skills and you know what they're talking about when they put in their read that they saw an anterior fat pad sign or they're talking about the anterior humeral line, you're going to want to know about that stuff. So let's talk a little bit about it and learn how to do it, and you'll feel a lot more confident when you go to read an elbow X-ray. So you're really going to get at least 2 views. Remember, for everything you're evaluating, you're getting at least 2 views on the X-ray. So you're going to go straight on that elbow and see it this way, and then you're going to get a lateral of that elbow, if I can get it in the screen there, and show them a lateral. You get a lateral view as well. And the lateral becomes really important in looking for fractures. In fact, that's the one you're going to see fractures on the most. So joint space really isn't a big factor here. If you see joint space widening, you know that there's dislocation. It's pretty obvious in the elbow. It's pretty hard to get dislocated elbow. So you're probably not going to see a lot of joint space widening, maybe with the radial head being dislocated, and we'll talk about that here when we talk about alignment and joint space there. So alignment, you're going to look for anterior humeral line and the proximal radial line, and I'll show you what those are in just a minute. If it is a true, and so that's part of the lateral alignment there you're looking for. Also, if it's a true lateral, alignment's big on laterals, like I talked about before. If it's a true lateral, there will be an hourglass sign or a figure 8 sign in that humerus, distal humerus, and I'll show you that here in just a minute as well. Okay, bone, when you're looking at bone, remember that often these fractures are supracondylar fractures are very subtle and cannot be visualized very well. You're looking for a very subtle little break in that cortex of that bone. Okay, and I'll show you an example of that too. Soft tissue, look for what's called an anterior and posterior fat pad sign. I think I showed you that already, but we'll show you that again. Okay, so let's look at it here. So first of all, we're looking for joint space. If we're following jabs, there's 2 joints here we're looking at. We're looking here at the humeral ulnar joint, or the elbow. Joint space looks okay there to me, and this is the radial ulna joint, and it looks okay to me as well. Okay, typically this one, if it's abnormal, it will be the joint space. It'll be dislocated, and that's why you'd have widened joint space. Otherwise, you're not going to have widened joint space there. It doesn't really get arthritis either. So alignment is the next thing we need to look at. And the first thing, this is a lateral view, so the first thing we need to check out, is there an hourglass sign? And you're looking for an hourglass sign right here. It's also called a figure 8 sign, and I think it's probably a better name for it is figure 8. And I don't know if you can see this, hopefully you can. I'll trace it with my cursor. There is a figure 8 right there in the end of that humerus. So you have the capitulum here that's coming off the end of that humerus, the condyles there. And they just make these 2 nice little round things. It's either called hourglass or figure 8. And if that is there, then you know that this is a true lateral. I'll show you a picture here next. So here's your 2 views of your elbow. This is obviously a child. But anyway, notice here that this is your lateral. Do you see that hourglass at all, or that figure 8? You don't. So you know that this is probably rotated a little bit in like this or out like this to make it distorted, and so it's going to be really hard to read the rest of this X-ray if it's not in proper alignment. Okay, so let's go here. Let's talk. I talked a little bit about anterior humeral line and radial proximal radial line. And this is what we're talking about here. So you look at the anterior part of the humerus. This is looking for alignment and looking for fractures that sometimes can be hard to see. And commonly the fracture involves the capitulum here, okay? And if you don't know what you're looking for, this capitulum can be swung back here and be over here. And you may not see that fracture on that lateral, and it may be really hard to tell if it's fractured because it looks like it's in normal alignment if you don't know what you're looking for. So what should happen is if you follow that anterior humerus down and draw a straight line straight through that capitulum, it should go through the middle third of that capitulum, okay? So here's 1/3, here's the 2nd third, and here's the 3rd third over here. So it should go through right through the middle third, okay? That is proper alignment. If that anterior humeral line dissects that capitulum over here, or it is over here, or it just doesn't even hit the capitulum at all, that means that you've got a fracture, okay? And I'll show you an example here in just a minute so you know what I'm talking about. We'll go through it in class. But anyway, that becomes important. The proximal radial line, if you go right through the middle of that radius and come backwards towards the capitulum, it should go also through that middle third of the capitulum, okay? So we're talking, here's the 1st third, here's the middle third, and here's the distal third. So it should go right through, and these two should intersect right. If it's a true lateral in the proper 90 degrees, they should meet right in the middle of that capitulum, okay? That middle third. If this line is off, so say this proximal radial line is dissecting that or crossing that capitulum in the proximal third or the distal third, that means that the radius is probably dislocated, okay? And sometimes that can be very subtle and hard to tell. Okay, so that's some little tricks that are very important when you're looking at lateral elbow x-rays for telling if there's a fracture. So let's look at a couple x-rays here. Okay, so let's follow JABS here, the acronym. So we're looking at joint space. This joint space looks beautiful, doesn't look too much. Joint space over here looks okay. Obviously this is a child because they have growth plate. Here's the epiphysis here, here's the physis, and diaphysis over here. Obviously growth plate here too with the capitulum right down here. So let's look for alignment. Do we see now it's kind of hard to tell in little kids if they have the hourglass sign. This one is probably a little bit out of alignment, maybe not, but you can kind of see how in little kids, because it's not all the way healed up yet, or not all the way grown, you can kind of see the circle there and the circle here, the hourglass. This one is proper alignment. Okay, so then we look for anterior humeral line. Let's follow that down. Does it dissect that capitulum right in the right spot? It doesn't. It dissects or crosses that capitulum right in the anterior third. So that tells you that this capitulum is swung back. Even though this is a growth plate here, it's hard to tell. You do see a little fracture there, right, when you're looking at the bone, but we're just looking at alignment first. That means that this is swung back, which means it's probably fractured. So we know that already from alignment. Let's go with the proximal radial line. Go right through the middle here, and that should go right through the middle third of that capitulum, which it does. So we know the radius is not dislocated. Then let's look at bone. So let's follow the humerus down. We do notice the cortex is ruptured right here, which we already knew there's probably a fracture there. We know this is out of alignment now. The rest of that humerus looks okay. We look at the radius, it looks okay. Again, this is a younger child. This may look like to some people like a break, but that is just the growth plate. Okay, and then we look here at the ulna, and it looks okay. Let's now look at soft tissue. Soft tissue, we talked about the anterior and posterior fat pad sign, and hopefully you noticed that already on this, but you notice how it's a little darker here, anteriorly to that humerus and posteriorly, not very bad, but a little bit. And remember, that shows up when there is intra-articular fracture, which we do have. Okay, so because that anterior humeral line was not in the right spot, we knew right away that this capitulum was not in the right spot. But you can kind of see if this fracture wasn't here, let's just block that out of the way for a minute. This would almost look like a normal x-ray until you use that anterior humeral line. So that's how you kind of read an elbow x-ray. Let's see, here's an obvious fracture. Well, let's follow the same thing. You can tell this is a fracture right off the bat, but let's follow the same principles to make sure we're looking for everything. So Is there adequate penetration? Yes, you can see the medullary cavity, you can see the cortex here. That's really what you're looking for. Is there proper alignment? Well, we can't really tell because it's so fractured here. You can't see your figure 8 or hourglass sign. Let's look and see, but probably a good true lateral. Let's try following anterior line. Obviously, it doesn't hit the capitulum. Let's go here. It does hit the capitulum there. So we do have a fracture in this one. If you look at bone, follow this around. This is grossly displaced and angulated fracture of the distal humerus. So you can see that this probably should have, this little piece here probably should be over here, attached here, and obviously should be coming over there. So we've got a angulated, probably 30-degree angulation and displaced distal humerus fracture. Radius is okay, not dislocated. Ulna looks okay. Soft tissue, we don't see any fat pad sign here, which is something we should know. Do you always see a fat pad sign if there is a fracture there? No, but if there's no fracture and you see a fat pad sign, you call it a fracture. Okay? Okay, so now let's talk about the wrist. Wrist also becomes really important when we're looking at alignment, and especially on that lateral, just like in the elbow. And the reason it is so important, when you are doing a wrist x-ray, you're looking for a distal or distal ulna or radius fracture or carpal fractures or metacarpal fractures. If you look at that x-ray straight on, you can see some of those fractures, but you may not be able to tell if they're angulated anteriorly or posteriorly at all. So you have to get that second view, is where the second view becomes very important. Then if you're looking at those distal radius ulna, you can see that angulation this way, or those metacarpals this way or this way. And that makes a big difference, because if you've got a bunch of angulation there, you need to go take them in to the ER, and orthopedist needs to come in and reduce those back into the right place. Okay, so let's talk about how, and it's hard to get a true lateral. You don't want, if it's rotated at all like this or like this, you're going to have distortion of that, and that angulation could be totally distorted, and then you may not do the right thing for that patient. So let's look at how you tell. So, kind of a simple drawing here. Here is metacarpal up here. Okay, here are your carpal bones, and here is your radius and ulna. These are all become kind of one shape because they're transposed on top of each other. In your carpal bones, you will see at the bottom a little moon-shaped bone called the lunate. That is why it's called the lunate, because it looks like a moon. Okay, you have your pisiform. This becomes very important in telling if your lateral is adequate or not. Your scaphoid bone, which is here, almost looks like a little dog sitting. Okay, that's how I kind of remember it. There's a little dog face right out there sitting down. And you have your capitate here at the top. You would like your pisiform to be inside that scaphoid bone, if possible. You don't want it clear over here. You don't want the dog sniffing that pisiform. You don't want him sniffing the pee. And you don't want him peeing the pee over here. Okay, I'm sorry, that's a very crude way to remember it, but that's how I remember it. You want it to look like the dog ear, basically. Okay? And you want that dog ear to, underneath it, have that border of the capitate within it. Okay? So here's some lines of kind of where you want it. See how that capitate line is within that pisiform, and it looks like the dog ear. So let's look over here. So here are your radius and ulna. Here are your carpal bones, or metacarpal bones. Here are your carpals. Here at the bottom you have your lunate. Okay, see how it looks like a moon. You have your scaphoid. See the dog's head there. And you have the pisiform here and the capitate here. So, is this in the proper alignment? Is this a true lateral? Well, does that really look like the dog's ear? It's maybe a little bit low, so maybe they're tilted a little bit like this. And it's maybe a little forward, but it's probably acceptable. Okay, this is an adequate film, not perfect, but adequate. Okay, it's right in the general region where you want it. That capitate comes right over in here and touches that pisiform, so we're okay. We know that's okay. All right, so there's that drawing of the pisiform superimposed on there. Now this one is a little bit harder to see. You can see the lunate really well here. You can see the radius and ulna, metacarpals. Here's your thumb. Here's the pisiform outlined for you. And here's the scaphoid. Notice that it doesn't really look like a dog's head anymore in this picture. And notice that pisiform is clear over the nose of that dog. That means that this is rotated and probably in this way, okay? So let me see if I can get my right hand there. So it's probably rotated in this way, okay? And that's distorting the scaphoid there. The capitate is right here, not even touching that pisiform. So we know this is not a good alignment here, okay? So this is rotated. So if you had any angulation here on this radius or ulna, distal radius or ulna, you would not be able to accurately tell how much that is angulated because that is a rotated film. Okay, so that's what you're looking for on a lateral. And this becomes important because even if you're not reading these x-rays, but you're performing them in your office, your MA is going to be doing that, or radiology tech if you're lucky. They're not always super trained, especially the MAs, at doing x-rays, and so they may not do proper alignment. You're going to need to check those x-rays to make sure they're good alignment. So when you send them off to the radiologist, he's not calling you back and saying, hey, I couldn't read that x-ray because it was rotated or it wasn't penetrated far enough or whatever. So knowing these things becomes very important when you're sending it off so you can get a good read and you're not having to bring that patient back in to do another x-ray or send them to the hospital or whatever. Okay? So this is not proper alignment. This is proper alignment. Remember, you want that pisiform ideally to be at dog's ear. Okay? Now let's look at just a straight on view AP of that wrist, especially the carpal bones here. And let's name all these carpal bones here really quick. So we have, let's start with the bottom row. We have our scaphoid here. It's this big long one. Next to it we have the lunate. That's the one that looks like a moon. Remember, it's at the very bottom. And when you look sideways, it looks just like a moon, just like that. And then we have our triquetrum right here. And the pisiform is superimposed on top of it. It actually sits on top of that triquetrum. So right in there. Okay, and you can do it on your own hand. Okay, right underneath the thumb, that's your scaphoid, lunate, triquetrum, pisiform. Okay, let's go up to the top row. This one right here is called your trapezius. And the way that I remember, or trapezium, not trapezius, I'm sorry, trapezium. The way that I remember this is that's where you're holding on with your thumb and your big finger onto a trapeze. And that's the bone that you're putting all the pressure on. That's a weird way to remember it, but that's how I do it. So trapezium right there. Okay, this one here is your trapezoid. It's trapped in here between your trapezium and your capitate. Okay, capitate is the one here in the middle. It's this big one, comes all the way down, touches the scaphoid and the lunate and all the way up. It's the big one in the middle there. And then you have your hamate. That's over here. And if you actually looked at it at a different angle, the hamate has like a little hook on it, a ham's hook. Okay, so that's your hamate. Okay, so let's go through these again. Scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. These are important ones to know if you're going to be looking at these x-rays. Okay, this is your distal ulna. You can tell this has an ulnar styloid. Ulna is always on the pinky side. This is your radius, distal radius. Okay, it's the bigger one of the two. So let's follow jab and let's look at this x-ray and see if we can find any fractures here. Okay, so let's look. Is this an adequate film? Yes, you can see the medullary cavity. You can see a cortex line there. The nice calcification. You can see good detail of the bone itself. So it has good penetration. This is an AP. We can't. It's probably not rotated. These are pretty easy to do, but it looks like it's good alignment. Let's look at the bones. We're looking at the bones. Follow them all around. This becomes very tedious when you are going through hand x-rays and wrist x-rays because there's so many bones. But you need to trace every line of every bone here, okay? So I usually take my cursor and just follow it around, okay? See where it's kind of superimposed on top of the other one, on top of the trapezium there. You've got to make sure that that is nice and smooth there. Go all the way around. This little bone up here is a sesamoid bone. If you come here on this metacarpal, first metacarpal, try to follow that line around. It's kind of hard because you've got the trapezoid that kind of gets superimposed there as well. And then here. Look for, also you're looking for joint space narrowing. We probably would have done that first, right, for following jabs. You can get some arthritis definitely in here in these carpals, and this will be, it'll be a lot whiter, okay? The color will be more calcified. It'll be kind of almost like this white over here, like this cortex here in these joint spaces if it's narrowed because of arthritis. And that's what you're going to see. You're not necessarily going to see a widened joint space there. Okay, and you follow all these. Make sure it's nice and smooth. There's a little bump right here, so there may have been a past fracture, and that's a callus formation there. Hard to tell. And then follow around all the carpal bones. So you can start with the top row, trapezium, trapezoid, capitate, and hamate. Okay, they all look okay. Scaphoid. Oh, I see a disruption of the cortex. You see that little line right there? That is a fracture of the scaphoid. Okay, good. Look at the lunate, look at the triquetrum and the pisiform. And then we go down here and look at the radius, the ulna. They look okay. So you won't always see, this has a scaphoid fracture, obviously, and it is in the middle third of that scaphoid. And that is very common, the most common place for that to be fractured. You won't always see that fracture. In fact, if they have snuff box tenderness over that scaphoid, that's your sign that they have, that you need to do a scaphoid x-ray or a wrist x-ray. It's usually from falling on their hands this way or back. So skateboarders, snowboarders get this a lot. If they have snuff box tenderness, you do an x-ray. Even if there's no fracture and they have tenderness there and they've had trauma, you put them in a splint or their wrist is cocked up a little bit. We'll talk about that in another lecture. But anyway, the reason is because there's only one blood supply. It comes from this way. And if that is broken off here, this part of that bone will die because that blood supply will be disrupted, and then you get necrosis of that bone and it can cause really huge problems later on. So even if there's no, and they're usually very subtle fractures, so usually if there's no fracture seen, they have tenderness, you put an x-ray on for 2 to 4 weeks, then you have them come back, re-x-ray, you'll probably see some growth there. If they're still having pain, you put them in for another 4 weeks, and then you can take them out usually. You may never see that fracture, and you may have to do a CT scan to see the fracture, but you always treat it like it's a fracture if there's pain there. Okay, that's a wrist x-ray basically. Okay, here's another example of some wrist fractures. This is actually a Colles fracture where you have a distal radius fracture. Very common, most common fracture that you're going to see in the family practice setting. We'll talk about how you treat this in another lecture here. You notice this one's in a cast. Okay, you can kind of tell where it's a very big arm. It looks like a cast to me. But anyway, notice, I wanted to show you this because it illustrates why the lateral is so important. So you have two views here of this x-ray, this wrist. Notice that if you go through the bones, you can see that this distal radius is fractured. Okay, so you have it this way and you have it, anyway, you can see it there, but then you do a lateral. You can't tell how angulated it is over here in these two, right? You do a lateral and you can tell exactly how angulated it is. Now, is this an adequate film? Is it in the right spot? Look at this pisiform, it's clear over here. That is not a good x-ray, it's rotated. So this looks angulated, but is it just because that's rotated a certain way as optical illusion? You need to get a true lateral to be able to tell. So this is not an adequate x-ray for the wrist. All right, next let's talk about the knee. So I've shown you this x-ray already and it's kind of small, but I'll put these PowerPoints up. Knees, we'll do some in class and go a little more in depth in class with knees. The big ones you're looking for, obviously if they have trauma, you're going to do knee x-rays. If they're having chronic pain, you're going to do a knee x-ray. You can see arthritis on a knee x-ray. You can see fractures, especially tibial plateau fractures. You can also see patellar fractures, those kind of things. And we'll go through it in class what kind of x-rays you need to order for that. If you're looking for the patella, you need to do a sunrise view. You can do laterals of the leg, of the knee, and that can show you some soft tissue stuff that we'll show you in class. But for this, to keep it short, let's just show you what arthritis looks like. So for following jabs, over here is your normal x-ray, right? Normal joint space. Over here, notice that joint space is not normal. It's nice and closed off over here, and there's a thickening of, or an increased density there, or increased calcification there on this side. that cushion, that pad, that cartilage, meniscus there is worn down. There's bone on bone. You have increased bone growth there. Narrow joint space. Okay. Is this adequate alignment? Yes, it looks okay. It's weight bearing. They're anterior, posterior. Looks okay to me. All right. Then let's look at the bone. Everything looks okay, except for over here, you're just getting kind of some spurring and you're getting that joint space is bad. And soft tissue looks okay. So this is a typically what arthritis looks like. And are you going to see arthritis in both legs? Yeah, you are a lot of times because they're going to wear both of them out at the same time, right? Not always, but you do. You can also see joint space narrowing in the middle on some x-rays, not on this one, but you can on some. So that's what you're looking for with arthritis. Ankle. So, ankle. I wanted to show you the ankle because you're doing ankle x-rays a lot when you are looking at ankle sprains. And this is a picture of an ankle sprain. You can tell because you can see the soft tissue over here is nice and ballooned out. Kind of hard actually on this x-ray. The big thing I wanted to bring up on this is the reason you do x-rays on really bad ankle sprains, and we'll talk about the Ottawa rules another day, and we've already probably taught you those. If they can't weight bear, they have tenderness over the malleolar zone, they can't walk at all on it, that's when you really need to get an x-ray. Those are the Ottawa rules. If they're positive for that and they've got this ankle sprain type motion, they've externally rotated or internally rotated that ankle and rolled it, they can get avulsion fractures, and that's what this is showing right here. It's a nice little avulsion fracture, so that calcification off in the soft tissue. That, and over in here, these are avulsion fractures where those ligaments have torn off and torn a piece of that periosteum off with them. And you can tell that it's torn off because you see it's kind of raggedy over here on that part of the ankle. Okay, so ankle sprains, that's the big thing to look for along with any other big fractures, but these are very subtle and can be missed very easily. Okay, foot. Let's look at foot. Another very common fracture you're going to see is called a Jones fracture. And that's what we're showing in this x-ray here. Jones fracture is on the proximal third of the fifth metatarsal. And it's right here. Okay, you can see that. That's from a kind of lateral motion, planting motion. Dancers get this a lot. Anytime you're landing on that outside edge of that foot really hard, you can get this. These are bad fractures because they have a hard time healing. Notice it's kind of an oblique to transverse kind of fracture. You get a lot of, because you're always weight bearing on this foot, it has a hard time healing, and you get problems with non-union, and they have to go in and do surgery on these. So this is a big one to pick up on. If you do pick up on this, you put them in a cast, a non-weight bearing cast for a good 6 to 8 weeks, maybe even 10 weeks. And then you re-x-ray, make sure it's coming together, and then you put them in a walking shoe for even longer after that. So that's a Jones fracture. Basically, just wanted to show you that so you know what it looked like. Okay? All right, and that concludes our ortho x-ray PowerPoint. Hopefully you've enjoyed it. We're going to go over these in class, do some case studies and things like that so you get some more practice at it. Don't feel anxious about these. They're pretty simple. Most of the time, these just like this one, these fractures are pretty obvious. And we've kind of talked about the common ones that are going to be occult fractures that are going to be hard, especially in the elbow and in the wrist with the scaphoid. So anyway, we'll talk about how to manage these in another presentation here for this week, and hopefully you've enjoyed it, and we'll see you in class.